Welcome to the HITea With Grace podcast, where we spill the tea on HIT. Today, I'm honored to welcome to the pod Dr. Stina Saunders, Personalised Medicine Lead at Linus Health. Thanks so much for joining me.
Thank you so much for inviting me.
So tell me a little bit about the career path that brought you to your role today.
I'm based in Edinburgh in the UK, in Scotland, and I've got a background in clinical psychology, 2 master's degrees, and then a PhD in clinical brain sciences, where I worked a lot with people with kind of pre-dementia stages, mild cognitive impairment, prodromal dementia, mild dementia, to kind of understand more about that at-risk population. And during my PhD at the University of Edinburgh, which was primarily supervised by Professor Craig Ritchie, then I developed some work around person-centered outcome measures. So the tools that we use to understand whether an intervention offers a benefit to people, whether it's a drug intervention or lifestyle-based intervention. So to understand if people really benefit from that. And off the back of some of that work that I developed during my doctoral studies, then this intellectual property was acquired by Linus Health, which is a Boston-based brain health company. And I was also offered a job to join the team there, the medical team, which I was really delighted about because it was straight from my PhD. And now I've continued to work on the same sort of research that I carried out in my PhD, and that's kind of carried over to my work in Linus.
That is so inspiring. I've actually been following your work for years and Linus Health for years, so I'm thrilled to have you on here to talk about your most recent research that just popped. You led research that found that the most meaningful aspects of a person's life are not being captured by traditional assessment methods in Alzheimer's disease and related dementias. Can you share some details on where the study was published and why this finding is significant?
This study was published in a journal called Alzheimer's and Dementia, Translational Research and Clinical Interventions. It was an invited piece of research to be submitted to their journal. And this is really taking that same approach that we developed in the UK and applying it in the US. And we were really keen to see whether the approach that we took with capturing these personally defined treatment priorities and also measuring how well people perceived to be doing in these areas of life, how well that would apply in the US. So really, it was kind of a proof of concept study in that regard. And what we found was very interesting. People were definitely able to engage with that approach that we developed, whereby we asked people to use their own words and define things that are meaningful for them. And that isn't done usually in research or clinical settings, where we tend to use questionnaires and outcomes assessments, which are the same for everybody. So your patient A and B and C get asked the same standardized questions. They rate how well they're doing in these same standardized areas. So we ask about people's activities of daily living or quality of life, which is kind of defined by the average and or defined by the clinician proposing these questions, administering the questionnaires. But we also know that many of these items in the typical tools that we use may not be applicable to everybody. For instance, we ask everybody about, are you able to do your own laundry? Are you able to do your own cooking? Are you able to look after your finances? Which seem very sensible questions around activities of daily living. But not everybody necessarily, that they don't do these things. Maybe people don't drive. They've maybe never done their own laundry. There's lots of culturally specific things here, lots of generational things. So it is really important that we ask people first what it is that how do they know that a treatment would be helping them? This is the very core of the approach that we're taking, that we are not defining the outcomes of success ourselves, but we are asking the patients individually to define all their outcomes. And then, like I say, assess how well they feel like they're doing against these things. I just want to say that this sort of approach, it doesn't replace using other assessment methods. We would still continue doing all of your objective assessments. You would do your bloods, you would do your MRI scans, you would continue your cognitive assessments to have an objective overview of your cognitive status. So all of that is extremely valid and important and relevant, but it's an additional corroboration or something that you measure objectively to capture that patient's voice as well, which is it's empowering for the person to be able to say that, yes, I feel that I noticed a change.
And it's just seeing the patient or the consumer, or whatever you want to call them, participant, seeing the person as a whole person, as more than just a number or more than just a yes and no on a sheet, and just really understanding the entire system around them. So it's my understanding, and you just kind of just mentioned that these findings indicate the need to embrace a personalized, culturally informed approach in deciding brain health care plans. Can you talk more about that kind of culturally informed approach?
Yes. So again, this is off the back of research that we've done over quite a few years, where we've seen that there are differences in how people define success, like I say, how they know that a treatment is working for them. Now, with this latest research, we see that there's differences between cultures. So between UK and US, for instance, we are using ePSOM in other cultures as well. We just haven't got to that stage where we're able to publish that yet. But it is the first instance that we've seen these differences between the UK and US. However, previously, we've also seen within the UK sample that there's significant differences between social demographic groups, between genders. Some of the findings that we found between what matters to men and women, they're almost too cringeworthy, because some of it was very stereotypical, where men reported things like rational thinking as one of the top priorities. And mind you, this is not something that's prompted, but it's individually defined by everybody. But we did find these significant differences. Also, those with a higher and lower education level, for instance, again, some of the answers conform more to sort of stereotypical view that those with higher education were more likely to say that things like discussing literature, discussing science, engaging in these topics is important for them. And that's how they would know that they're doing well or they're noticing some decline in their brain health. And also age groups, we've seen differences. So those who are, I think, 64 and older and under that age, we noticed things around how much importance was given to sense of humor. And it was particularly the younger age group who said that things like making others laugh was something that mattered to them. And you can kind of interpret these findings whether that's something to do with your kind of agency or sense of self, that's something that's important for you and it makes you, that social engagement side. So because we have that evidence, and in many ways, we know that the people are individuals and everybody should be given that chance to kind of not conform to the average, then these sorts of things should be taken into account when we measure longitudinally treatment success. And particularly when we talk about clinical care, then the treatment decisions should be around the things that are meaningful for the person, that we know certain interventions, certain drugs, that they may come with side effects, and that discussion between the provider, the clinician and the patient should always use as an anchor the particular sort of priority outcomes that are important for that person. So this is a way to systematically capture them and monitor that we are really kind of addressing what matters most to that patient, as opposed to maybe looking at objective outcomes only and numeric outcomes only.
So wild that it kind of always was that way in terms of the objective outcomes being the main focus and these kind of subjective outcomes being left out. Were there any other interesting findings from the study that pique your interest for future research where you're like, whoa, that was really interesting? I wonder if we could dive deeper into that.
Yeah, absolutely. So on the one hand, a lot of the data that we collect is by its very nature, is very, very interesting because that we collect free-form data from people and you always get a really rich data set from there where people use their own words and they define their priorities. I mean, one thing to note is just the sheer breadth and heterogeneity of things that people define as important. There's hundreds of themes that emerge from this data set. In the UK, we had a larger sample. We had about 4,500 people who are included in the paper. In the US, we had a slightly smaller sample, just under 800 people. But we used proportional comparisons between these populations to be able to compare them. And like I say, the sheer number of unique priorities itself is very interesting. And again, to compare the sorts of tools that we normally use, which things like EQ5D, a commonly used quality of life measure, which has 5 outcomes, and everybody gets asked the same 5 things. Some of the activities of daily living scales or instrumental activities of daily living scales, which have again, very limited number of items, up to maybe 10 items. But we see that that's just not adequate, and why should we squeeze everybody into these predefined themes? So that was interesting. But also the way we prompt people to sort of define these important areas of their life is that we present people with 5 domains, sort of overarching domains, which are off the back of our previous research of sort of high-level areas of life that are important for people. And one of the domains, the last one, is your sense of self or your sense of purpose. And I always find these answers really interesting that come in from there. And that's something that was indeed out of scope of this paper, but something that I would like to delve into a little bit more, to kind of see what sort of neurocognitive domains underpin a lot of these sense of self priorities. And my first reading of the data is that a lot of it is around social cognition. So rather than necessarily being around sort of memory or maybe executive function, and particularly in Alzheimer's disease case, then so much of our treatment and our focus is always around memory, to test you were previously able to remember 8 words out of 10. How many words out of 10 are you able to remember now? But like I say, the sense of self, sense of purpose domain really seems to focus a lot around the social aspect and the sort of perceived things like ability to give advice. A lot to do with agency, I would say. So that's a really important, interesting finding.
Fascinating. So fascinating. Now, I'd love to talk all things ePSOM now. So the electronic person-specific outcome measure tool that you guys developed in the UK, and now it's expanded to the US. Can you tell me a little bit about this tool and how it helps solve some of the challenges we just talked about and what you were just speaking about?
Sure. Thank you. So this tool, it's developed in the UK with an initial collaboration between us at the University of Edinburgh at the time, because I was fully with the university at the time, one of the largest dementia charities in the UK, Alzheimer's Research UK, and also some input from the European Medicines Agency, EMA, with the recognition of some of these issues that we've spoken about today, really initially thinking about drug development, that we're developing treatments for Alzheimer's disease where the outcome measures or the endpoints that we use to understand whether a study and intervention has been effective doesn't necessarily capture the patient voice. And really to understand whether an intervention offers value, then it needs to really demonstrate that the people who are using it and the people who are taking risk to take this medication are really getting something back for it. So that was the initial premise for considering how do we address this? How do we bring that patient voice in? And off the back of that, we developed a program with kind of several steps where each of the previous steps informed the next step. We carried out a literature review to understand what sort of patient-reported outcome measures or PRO tools are being used just now. We concluded that there aren't individualized tools that are being used in Alzheimer's disease and related dementias, which is somewhat different from some other areas of medicine. Things like cancer are better at being person-specific, but for some reason, particularly in the sort of dementias areas and neurodegenerative areas, then we kind of don't seem to have the tradition of bringing in the patient voice that much. And what's more, we may also rely quite a bit on the care partner's view, which is very important and should be considered. But also, we shouldn't just override the patient in the maybe expectation that there might be some loss of insight. But certainly in the earlier stages, we know that people are very well able to kind of communicate their priorities and how they're feeling that they're doing, and that should be taken into account. So we developed a stepwise program, carried out some focus group studies to really understand qualitatively in depth from people with dementia, those at risk of dementia, some healthy volunteers and clinicians, the sort of areas that tend to matter the most to people. And we just got some really interesting findings from there. And one of the ones was around self-reported confidence. Okay, so how confident I feel in doing something. This was remarkable because it came out both from sort of the people that we interviewed and the clinicians. It's very complementary of each other, where people said that some of the early things that they notice is losing confidence in areas where you've previously been able to do something well, something that is important to you. And they would say things like booking my own travel, kind of like complex instrumental things to do, but something that has been meaningful for you. Leadership skills, kind of backing yourself, more kind of intrinsic than just going straight into loss of independence in managing my finances, because that's clearly so much further down the line. But these first initial things are much more subtle, and people really identified with this confidence notion. And then again, with the clinician side, this is what the clinicians also observed with their patients. And they said that if an intervention is effective, then it's not necessarily hard and fast. That, like I said about some of these objective measures before, that you necessarily see a big jump in somebody's performance objectively on assessments, but it's more around soft things like feeling more confident in yourself in something. So this is why when we took kind of our learnings from these previous steps and we proposed this outcome measure, which is designed in a way that people define their outcomes, they define their priorities, they say, okay, what sort of things matter to me in these different domains that I'm being shown? Remembering things, keeping a tidy home, being house proud, things that are specific to people, critical thinking, sense of direction, in enjoying walking outdoors. And then each of these items that people define as important, they then rate their confidence in how well they think they're able to do this. And like I say, this is why we used confidence as the construct for the scale. So that's where that tool has come from, ePSOM. And now this tool is being used in quite a few different studies across different populations, a couple of studies in the US, which haven't read out yet. So we don't quite have that data yet. Different studies in Spain, Japan, other countries that are kind of trying to employ the same approach.
So inspiring and so empowering too, to really see that the patient voice is being put at the center of something that has to do with them. What a shocker, right? And just, it's like about time. And thank you so much for spearheading that, and you and your team really leading the charge and making sure that that is happening. That the patient-centered, patient-focused care and research is at the center. And I'm just so inspired by you. So my listeners love to learn from people about what's going on in the industry, but they also love to learn from women about what wakes you up in the morning, what helps you work your best to make a difference. So are there any habits that you have in your life that really give you that oomph to keep going?
It's a good question. I suppose the one thing with work is to be really passionate about your work. I think I've been very lucky with the company that I've ended up working in with Linus. I think that's just the main motivator, that you feel that your work is meaningful, that your work is, I suppose, valued internally. But also, I very much recognize that I've personally been very, very fortunate to be able to continue some of the work that I did in my PhD into industry now. And I very much recognize that that's a difficult junction when you finish your PhD and kind of how you implement your expertise. So I think just being really grateful that I can draw on a lot of the experience from earlier in my career to implement this now in Linus. And Linus really champions kind of person-centered approach. It's all about empowering the individual, and that really drew me into that company, and I can really relate to that approach. So it's a combination of finding a really nice outlet for something that you're passionate about.
Absolutely. And we all know research is so hard. There are challenges, roadblocks, and they're constantly coming your way and just smacking you in the face, and you have to pivot. So what are some things that you do to overcome those challenges or to keep going even when they come your way and it feels unsurmountable?
Yeah, I think first thing to kind of observe, and that I always acknowledge, is that just about every problem is solvable. It's about understanding how's this problem come about, what's the sort of conflict of interest that's come about. And I personally always try to be kind of constructive, and rather than reactive, then just try to kind of calmly think through about how we can problem solve. And I always think I learn a lot from other people who are successful around me, other women, for instance. And I always think, what do they do that's serving them really well in their career? And it's just something that I've noticed has always been being constructive, working through a problem, kind of staying level-headed, which I don't know, maybe it sounds really quite boring. That's something that I've noticed seems to be, yes.
Instead of seeing it as a problem that's just stopping you in your tracks, it's seeing as a redirection and like just totally changing your perception of it. And that's absolutely something all of us need to know and implement into our lives. Like just because a challenge is coming your way doesn't mean that it's the end all. Like we can really find a way to get through it. There's always a solution. I love that. If you could give your younger self a piece of advice, what would that be?
Well, maybe I know you're listening to your podcast that you talk about women in healthcare, women in science in that regard as well. And maybe I'd approach it from that side. I mean, I'm still fairly early in my career in that regard, but I think I'd maybe encourage myself more because I'm a scientist and in science, it's all about the ideas that you have. Maybe to be kind of almost like less apologetic about having ideas and not feeling like you need permission to kind of develop an idea further. Because I think, I mean, I'm sure it's true for everybody, for men and women, and not just people in science. There can be a little bit of imposter syndrome where you think, should I be pursuing this? And is it really worthwhile? And will it sound silly? Sort of thing. But to back yourself and back your ideas, I think that's what I would say. Yeah.
To finish this conversation off right, where can our listeners find you online?
So I use LinkedIn. I don't use X or Twitter anymore for maybe obvious reasons. But yes, I'm on LinkedIn and I'd be delighted to connect with anybody.
That's terrific. Now, before I forget, did you happen to bring tea with you today? And let me see your mug, if so, and tell me about it.
I did. So I've got a mug, which looks quite dark now, so you can't see it that well. But at the start of the interview, it was bright with images. So it's a mug, which is it's a heat sort of reactive mug, which my son and I gave my husband for a Father's Day present.
Oh, and it has lots of lovely photos of her family on it. That is so sweet. That is a wonderful gift. And it's so funny that at the start of the thing, we're sipping tea over here and I can see the photos and gradually it's getting darker and darker. It's like, did you change your mug?
No, it's actually brilliant because it reminds you to like have your drink before it's all gone. As a family, we really love travel. We're really adventurous. So yeah, lots of our stuff has travel photos on and memorabilia.
That is too good. Well, thank you so much for joining us today. It was awesome learning from you.
Thank you so much. And I love your podcast. So yeah, so privileged to be on it. Thank you.
Thanks. And thanks to you folks for joining us too. Check out the HITea With Grace podcast for more interviews with great guests like Stina today. Cheers. Like a Girl Media is more than a media network. It's a community. We want to meet you and amplify your voice and the voices of outstanding women innovating in healthcare. Interested in starting your own podcast or hosting an event near you? Connect with us online or in person. We're here to support and empower you.